Hello, my name is Kelly Tebow, and I'm with the New Jersey Center for Tourette Syndrome and Associated Disorders, and I will be your organizer for this evening and would like to welcome you to our webinar on improving social outcomes for children with Tourette Syndrome and other neurodevelopmental disorders. Thank you all for joining us. Before I have my colleague introduce the speaker for tonight, I'm going to cover some housekeeping items with you. All participants are muted. If you have a question, please type it in the bottom of your question box and click send. You may send questions during the webinar. However, we will have Dr. Theobald answer the questions at the end of her presentation. We will get to as many queries as time allows. In addition, tonight's presenter is available to take your questions on the Wednesday webinar blog, which is accessed from our homepage under the heading Programs. This blog will be monitored for the next 7 days. Feel free to look and post questions as often as you like. Answers will be archived for future reference. If you missed part of the presentation or would like to watch it again, an archived version of the webinar will be posted to the website. We value your input, and in order to expand the webinar experience in the future, we need everyone to fill the survey out as they exit the webinar. The New Jersey Center for Tourette Syndrome and Associated Disorders and its directors and employees assume no responsibility for the accuracy, completeness, or objectivity or usefulness of the information presented on this site. We do not endorse any recommendation or opinion by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now, I'm going to turn over the introduction of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Kelly, thank you, and good evening, everyone. Welcome to tonight's webinar. Before I introduce our presenter, I'd like to take a couple of minutes to bring some upcoming NJCTS happenings to your attention. Our next Youth Advocate training is scheduled for Saturday, March 21st in Baskin Ridge, New Jersey, for kids between the ages of 10 and 17. The objective of our youth development program is to provide young people with TS the opportunity to develop courage and confidence while also learning to embrace their differences and advocate for themselves and for others. We are still accepting applications for Educator of the Year, which is about honoring an educator who has made a difference in the life of a child with TS. This award is not restricted to classroom teachers. School nurses, guidance counselors, and others on the faculty or staff who have made a difference for your child are all eligible for this award. Additionally, we continue to accept scholarship applications from high school seniors. Applicants must be residents of New Jersey, have a TS diagnosis, and are continuing their education in a 2- or 4-year program. Finally, there is still space available for families who want to attend our family retreat weekend. That would be June 5th through 7th, being held this year at YMCA Camp Bernie in Hunterdon County, New Jersey. Kids participate in a broad range of outdoor activities, rekindle old friendships, and cultivate new ones. There are many opportunities for parents to do activities with their kids, but also to connect with other parents and share their stories. Workshops provide a safe place for both youth and parents to ask questions about TS and learn from peer mentors. Now to the introduction of Dr. Azlen Theobald. Dr. Theobald completed her doctoral degree in clinical psychology at LaSalle University in Philadelphia with a concentration in child and family psychology. She completed an American Psychological Association internship at Terry Children's Psychiatric Center in Newcastle, Delaware, and has also trained at Children's Hospital in Philadelphia. She specializes in providing neuropsychological evaluations for various populations across the lifespan, from toddlers to older adults. Areas of expertise and specialization include Tourette Syndrome, attention deficit hyperactivity, autism spectrum disorder, traumatic brain injury, and dementia. She has conducted research among elementary and middle school aged children to identify effective interventions designed to improve knowledge, perceptions, and attitudes towards children with neurodevelopmental disorder. Dr. Theobald is a clinician at NeuroAbilities Healthcare in Voorhees, New Jersey, which specializes in providing care for those with neurodevelopmental and neurological disorders. Now, without further introduction, I'm pleased to turn tonight's program over to Dr. Theobald.
Thank you so much for that warm welcome. And thank you to our attendees for taking time out of your day to attend this webinar. I'm very excited you're here and to talk about this topic. I was introduced to learning about the neurodevelopmental set of disorders by Dr. Judith Newman, who was one of my professors and mentors at Penn State University. And her area of expertise was children's concepts of illness, and more specifically, the impact of a child's diagnosis and symptom presentation on his or her siblings. Dr. Newman has been involved personally and professionally with NJCTS, conducting training sessions, and she's conducted support groups. Some of you may even be on this call who have known Dr. Newman, and she's a very valued member of their community for several decades, and she's a very dear friend of mine. In my doctoral program, I worked with Dr. Diana Montague in the area of emotion development among young children, and from there I really began to develop an interest in how children formulate and conceptualize differences in peers. And I thought if I could use existing knowledge about what the literature has shown regarding how children formulate concepts of how or why a peer is different from them, then perhaps we could work toward developing interventions to really bridge that gap and help peers develop a more accurate understanding of one another that are developmentally appropriate. So I'm grateful to my past mentors for introducing me to these areas of research and allowing me to learn from them and continue on this trajectory toward building resilience among children who have neurodevelopmental disorders. On a personal note, I know many of you who registered for this webinar are parents who have a child with Tourette Syndrome, or perhaps you're a caregiver of a child with Tourette's. And part of what drove me toward learning more about this population and how to improve their social success is that I'm not only a clinician, but I'm also a parent of a young teenager who has struggled with tics since she was about 7 years old. And now that she's in junior high, I live with the daily struggle of wondering if today was a success or was this a perceived failure. So I truly empathize with those of you who are doing your very best day in and day out to help support your child as best you can. And I applaud the teachers and mentors and school personnel who are really the bright spots and safe havens in your child's day. And they're really the first line of defense when things do go wrong at school for these kids. So we're going to talk tonight about strategies that can help children feel more comfortable and more accepted, which will hopefully improve their social outcomes. So a couple of objectives for tonight are to first outline the criteria for a Tourette syndrome diagnosis. And second, we'll talk about the influence of stigma and rejection among children who are of different neurodevelopmental presentations. We'll discuss ways children perceive others from different stages of development and interventions that have been studied to date to help improve peer acceptance. And lastly, we'll discuss interventions that I and others have more recently considered to help improve peer acceptance and how parents, teachers, and caregivers can help bridge that gap between peers to help our children feel more safe and more comfortable and ultimately really enhance their self-esteem and resilience. So first off, let's just review quickly the DSM-5 criteria for Tourette syndrome, autism spectrum disorder, and ADHD. So these are kind of like the core neurodevelopmental disorders. And Tourette syndrome, to meet that criteria, first, it's a heritable neurodevelopmental disorder with having 2 or more motor tics. So for example, that's blinking or shrugging the shoulders, at least one vocal tic that could be humming, clearing your throat, or in very rare cases, yelling out a certain word or phrase. Although these tics might not always happen at the same time, you must have had tics for at least 12 months. The tics can occur many times a day. They're usually in bouts nearly every day, or they could occur off and on. Tics must have begun before the child was 18 years old, and the symptoms are not due to medication, other drugs, or medical conditions like Huntington's disease or post-viral encephalitis. Autism spectrum disorder, according to the DSM-5 criteria, is persistent deficits in social communication and social interaction. It's really across multiple contexts, and it's manifested by deficits in something called social emotional reciprocity, as well as deficits in nonverbal communicative behaviors that are used for social interaction. Also manifested by restricted or repetitive patterns of behavior, interests, or activities, things like stereotyped or repetitive motor movements, this hyper or hypo reactivity to sensory input, unusual interest in sensory aspects of the environment, and the symptoms are present in the early developmental period, and they do cause functional impairment. And ADHD, that is 6 or more symptoms of inattention for kids that are up to age 16, 5 or more for adolescents age 17 years and older. Symptoms of inattention must have been present for at least 6 months, and they're inappropriate for their developmental level. For hyperactivity and impulsivity, there's 6 or more symptoms for kids up to 16, 5 or more for adolescents age 17 and up. And the symptoms, again, must have been present for 6 months to an extent where it's really disruptive and inappropriate for that person's developmental level. Again, symptoms have to be present before age 12 and in 2 or more settings. And again, they have to really interfere with or reduce the quality of school, social, or work functioning. So since we're focusing on Tourette syndrome at this time tonight, I just wanted to give some brief statistics from the CDC's most recent 2012 study. We don't know exactly how many people have Tourette syndrome. There's studies that included children with diagnosed and undiagnosed Tourette's. Those have estimated that about 1 in every 162 or 0.6% have Tourette syndrome. According to parent-reported data, 1 in every 360 children ages 6 to 17 in the United States have received a diagnosis of Tourette's. So that's about 138,000 children. So this really suggests that about half of children with Tourette syndrome are not diagnosed. And among those diagnosed, 37% have been reported as having moderate to severe forms of the condition. Boys are 3 to 5 times as likely to have Tourette's than girls, with non-Hispanic white children twice as likely to have a Tourette syndrome diagnosis compared to Hispanic and non-Hispanic Black children. Worldwide, there's a prevalence of 1% of the population having the diagnosis. So a couple of parents' perspectives that I've looked at. This was culled from a large group of parents, answering questionnaires about their children's symptom presentation. They really first noticed tics in their children at about 6 years of age on average. So that's early elementary school. The average time from initially noticing tics to actually receiving a diagnosis was about 2 years. The average age when Tourette syndrome was most severe was about 9 years of age. And most parents reported their child's tics were noticeable to strangers. Tic severity really interfered with their daily functioning. So the more severe the tics, the more impairing for the child. And almost 70% of parents reported that major changes like starting a new school, moving to a new classroom, or fatigue made their child's symptoms much worse. Here's just kind of a graphic of just to show you the extent of overlap or comorbidity of Tourette syndrome with a number of other difficulties that children can face. So you see, like Tourette syndrome it rarely occurs in a vacuum. And looking on the National Survey of Children's Health study from 2012, surveying children ages 6 to 17, you can really see just the percentage of kids with Tourette syndrome having another condition. So 86% of children who are diagnosed with Tourette's also have been diagnosed with at least one additional, could be either mental health, behavioral, or developmental disorder. So that could be ADHD with the highest prevalence, other behavioral problems, mood difficulties like depression, anxiety, autism spectrum, learning disabilities. So you can really see just how impactful that this can be for children and for their families. So when we consider that large proportion of children with Tourette's who also have comorbid ADHD, we can imagine that these difficulties are quite noticeable to peers. And previous studies have shown that children can recognize individual differences in their peers by about the age of 3. Compared to children with physical disabilities like blindness, children with neurodevelopmental disabilities encounter social scenarios like teasing and rejection, and they experience greater difficulty in maintaining friendships, which really presents a significant risk for adverse physical and mental consequences like stress, low self-esteem, depression, and anxiety. And because children, especially in the early elementary school age range, often associate one's behavior to be within their control, so they're able to control what they're doing, these children make inferences that a child who is exhibiting symptoms associated with a disorder that's not physical in nature, so that may be getting out of his or her seat, being hyperactive, versus being in a wheelchair using a cane. And those inferences are often negative because children attribute symptoms of peers with neurodevelopmental disorder as very intentional in nature, especially at these younger ages. So students with neurodevelopmental disorders like ADHD and autism spectrum disorder and Tourette's can experience limited friendships and exclusion from social activities with peers. And as a result, they're really deprived of important socialization experiences and opportunities that help develop and refine their social skills and really are important sources of social support. So peer rejection in childhood, it predicts a wide range of externalizing problems in adolescence, including things like delinquency, conduct disorder, attention difficulties, and substance use. Children who are accepted by their peers, on the other hand, they tend to show better school adjustment. They have higher quality friendships. They're friendlier, they're more cooperative, and more adept at initiating and maintaining social interactions compared with other classmates. Children with neurodevelopmental disorders are much more likely to experience bullying behaviors as well compared to neurotypical children. And just to make sure we're all on the same page, bullying is really a behavior that must occur repeatedly. So one incident or some teasing doesn't quite constitute bullying, even though it's very difficult for parents to have to kind of navigate with their child, and very difficult for the child to have to experience. So once the bullying is repeated, it really becomes dreaded by the victim. It also has to include a power differential. So it could be a bigger in stature person toward a lesser stature individual, and it could be in social situations as well. So bullying takes a lot of forms, like aggression, but also teasing, gossiping, shunning or rejection, and using looks or gestures to really deride. So it could be eye rolling or a certain glare. Cyberbullying is also a huge problem in that kids really no longer have the safe haven of leaving school and feeling that relief away from a peer. So bullying often follows kids from school to home. And for kids who have access to their phones or devices at night, and as I'm sure, I know my children do, I'm sure yours do as well, those attacks can really continue well into the night when parents are unaware of the extent of the frequency that a child is getting targeted. So, when I was in high school, we didn't have phones. So you went home, and if you were having difficulties with a peer at school, you were kind of, away from it. You were able to breathe a sigh of relief. And now these kids really can't, neurotypical or not. So it's a very difficult, situation with cyberbullying. Among children with disabilities, they are bullied at a high rate, particularly during the middle school years. And the victimization rate for children with autism spectrum disorder in particular is substantially higher than what we know is about 10% rate for typically developing children. And it can really become quite a vicious cycle. So not having friends makes a child with a neurodevelopmental disability like autism or Tourette's really vulnerable to bullying. And being a victim makes a child with autism or Tourette's much less likely to get friends. And then we really have the beginnings of comorbid depression, social anxiety, and things like that. So the frequency of either being bullied overtly or rejected, it's highly associated with the load of the psychological issues that can go on in this population. And why are they socially isolated? Well, there's this social blindness among kids with autism that can include things like not knowing how to read other signals or understand social hierarchies or social cues. And these kids really have difficulty knowing what's considered, cool. So knowing hidden social rules like, the popular girl placing her bag on a chair, and then a child sits on that chair can lead to rejection and negative consequences. So kind of not really knowing those social rules. And kids with Tourette syndrome, they tend to self-isolate, to hide or minimize their peers noticing their tics. And in the long run, these kids can lose self-confidence. They can engage in school refusal or a decision where it's kind of forced to homeschool children. Fear, emotional upset, and reversion to even being more introverted if they were a child who in early elementary years were considered to be more extroverted, and feeling like They lose trust in others, and this often persists well into adulthood. When children feel accepted by their peers, though, it really leads to better school adjustment, higher quality friendships. They're more cooperative in their play and social engagement. To improve peer relations for children with disabilities, it's really necessary to understand the context in which kids make inferences or assumptions regarding the personal responsibility that a disabled child bears in regard to his or her challenges. And a child's cognitive level of understanding this context, as well as a child's exposure to the disability, so whether that's through contact with a sibling or a friend or a parent, that's also a big contributing factor in the attribution process. So in psychology, this is known as something called attribution theory. And attribution theory, in essence, assigns some kind of causality and responsibility to someone's behavior. So it serves as our mind's kind of perception of why a person is acting a certain way. And in children, this is really dependent on their cognitive level and the level or amount of experience with or exposure to that disability. So for a child who may have a parent with a physical disability, they may be much more likely to approach a peer who has a physical disability compared to a child who has no exposure to it. So looking at some interventions that were designed to improve peer attitudes toward a child with differences, literature has identified something called factual information to be helpful in the positive attitude development toward peers' neurodevelopmental or physical differences. So that translates into providing kids with facts, factual makes sense, facts about a peer's symptoms. And that could look something like Tourette syndrome is not something I can control. Purely factual, informational. And giving kids facts has been positively associated with improving younger, but not older children's perceptions. And we'll talk about that a little bit later about why that may be. The other intervention that's been considered and used in anti-bullying interventions is giving kids examples of ways they are similar to one another. So these are kind of descriptive terms that are designed to build sameness. So here we're putting kids really on an even playing field and defining ways in which they're similar to bridge that gap in the manner in which they see themselves as different and often more superior in social status than a neuroatypical peer. So again, these interventions work better among younger than older kids. And the reason for that is because as children progress into the middle school years, they become more aware of the importance of social status, and they're less likely to engage with a peer who may be different from them, even though they know logically the child is not engaging in specific behaviors just to irritate others or for attention-seeking purposes. And by the time children are ending elementary school, they're much more likely to attribute biological and neurological explanations into the way they kind of conceptualize children with autism, Tourette's, ADHD, for example, as compared to younger children who really attribute symptoms of ADHD, for example, to that individual's control. And what this means is younger age children, so we're talking like kindergarten to third grade, tend to have more negative associations toward children with differences, largely because they believe there is some purposeful intention of that other child's behaviors. So the kid with ADHD who can't sit still, or child who's sniffing repeatedly or humming repeatedly or whatever the tic might be, those kids are more likely to be seen as doing those behaviors on purpose in the younger grades. And once kids are really in 5th and 6th grade, they're much more aware that kids with Tourette syndrome or autism are not responsible for those behaviors, and they're cognitively able to figure out, like, hey, there's some other factor going on here that's really not in that child's control. So it's really not surprising that giving older kids more information, more of these facts about a peer's differences doesn't really help increase the likelihood that Rachel is going to invite Sarah to her sleepover, or that Zach will invite Michael to see a movie. And as parents, really all we want is for our children to have at least one meaningful relationship, one child with whom they can connect with and feel a social bond, because that makes all the difference in a child's day, which can often be riddled with rejection, no one to sit with at lunch, or running to the nurse or the bathroom when it's time to select partners for group projects, so they can avoid that awful feeling of being the one kid who didn't get picked to be in the group. So now what hasn't often been considered, although many of the anti-bullying programs do try to incorporate this into their curriculum, is the component of empathy in peer integration programs. And empathy is really different from some sympathy. Empathy is the ability to understand and share the feelings of someone else. And emotion researchers generally define empathy as something like the ability to sense other people's emotions, coupled with the ability to imagine what someone else might be thinking or feeling. So really putting yourself in someone else's shoes. It's really just perspective taking. And that concept it's difficult to teach in younger children because they haven't quite mastered that part of their brain development. So kids begin to show empathy around age 2, but their mastery of emotion and cognitive empathy really takes place and practice. It takes experience and practice, and this generally doesn't emerge until about age 7 or so, which is 2nd grade. And we know, according to prominent folks in psychology like Albert Bandura, social psychologists, that the importance of observing and modeling the behaviors, attitudes, and emotional reactions of others. And that really continues to develop as children's executive function skills mature, so that frontal lobe development is really critical. And they become more capable of managing their own distress and gain that cognitive space that they need to connect with another person's experience without feeling totally overwhelmed themselves. And it's really not until middle school childhood that these advances are seen in children's developmental skills, and this is the time to intervene. So we know that the key components that factor into a child's positive attitudes toward a peer include their ability to take perspectives of another and their capacity to imagine what others are thinking and feeling. And it really isn't until those middle childhood years, so we're talking like 3rd grade or so and up, 8 to 11, that kids are really advancing in this area, in this core developmental skill. We also know that there's sex effects of peer preference, particularly in the elementary school years. And across the cancer and obesity literature, it was found that when presented with vignettes or short stories about girls and boys with and without cancer, girls rated girls more favorably than boys, and that boys rated boys more favorably than girls, regardless of whether cancer was present or absent in the vignettes. And we also found this in obesity literature among girls, but not boys. So the purpose of this study that I conducted was to improve peer acceptance and behavioral intention. So when I say behavioral intention, that's the likelihood that a child would ask a peer to sit at his or her lunch table. And this in turn would help inform disability awareness trainings across various settings, including academic settings. So that was the main goal. Some experts in the realm of emotion development have said that empathy is caught, not taught. So of course, these skills and behaviors emerge and unfold differently for different children and depend on context as well. So we really can't sit our children down for formal lessons in empathy, and now you're going to get your empathy lesson. And that's tough to do in the classroom too. Instead, empathic responses really emerge over time in the context of warm, caring relationships that modeled appropriate relationships seen at home, storytelling, communication, and playing. And understanding whether a specific type of information or the combined effects of information is most effective can really help schools and teachers in providing better sensitivity training and simplify the informational process of helping children in their classrooms understand differences between them and a peer with a disability. So I was particularly interested in Tourette syndrome for a couple of reasons. One, because of my own personal experiences of having a child who struggles with tics, and 2, because there really wasn't much literature in this specific realm that was seeking to understand what it is about Tourette syndrome that puts these kids at risk, significant risk for social rejection and negativity. The Tourette's prevalence rates are relatively low, but the noticeability of symptoms is really high. So this is a condition in which kids likely don't know much about it, and we kind of had the luxury in my study of targeting children who were somewhat of a blank slate as far as their prior knowledge or biases that they may have developed over time about Tourette's. So what I did was I looked at which type of information was most successful in improving typically developing children's attitudes and positive behavioral attentions toward a child with Tourette syndrome. And to do that, I created 3 different video interventions called the Philadelphia Emotion and Social Cognition videos, along with Dr. Diana Montague. And these featured a boy and a girl presenting 3 different sets of information. So one video presented just knowledge about Tourette's. One presented just empathy statements, such as, I feel sad when I'm left out of a game, or when people don't pick me to be on their team. And then there was one combined video that merged these 2 pieces of information. We targeted 3rd and 6th graders to really target that kind of emerging time when kids are beginning to have that, strong frontal lobe development, empathic skills development. We really wanted to see which set of information worked best in the way these children rated a peer with Tourette syndrome. And now I should mention that the child that was portrayed in each video was a neurotypical child who was a trained actor, portraying both motor and vocal tics, because we really wanted to keep the presentation of symptoms consistent across the 3 videos. So we targeted 7 private and parochial schools in the Philadelphia suburbs. And they were very demographically consistent. We looked at about 200 participants and with little to no prior information about Tourette's, and these were 3rd and 6th graders, like I mentioned before. What we found was that kids learned a lot of information from the video that gave them just factual information. So things like, I was born with Tourette's. I'm not doing these behaviors on purpose. I can't control them. You can't catch Tourette's like you can catch a cold. Purely factual information. And kids who are presented with the video of the child just evoking empathy learn the least about Tourette's. Not terribly surprising. But the kids who learned the most were the ones who were presented with the video that combined facts and empathy about Tourette's. So you see that combined dotted line in the slide, that first line, the top one. And why is that? Well, because kids do pay more attention when there's an emotional component to what you're learning, adults as well. Did you ever notice that you're more likely to remember events in which you had some kind of emotional attachment? So a graduation or a new job or becoming really sick or where you were when 9/11 happened. We also interestingly found that whether you were in 3rd or 6th grade, the children generally learned about the same amount of information about Tourette syndrome. So we didn't really see any great effects on knowledge learned. So again, you can see that after children watched the video, we kind of looked at their knowledge of Tourette syndrome again, and we compared it to before they watched the video of how much knowledge they have. So now we examine the beliefs about the child in the video if kids were provided appropriate knowledge about the child. And beliefs and attitudes are 2 very different things. So I can believe that the child in the video isn't doing the tics on purpose, and I can believe that he or she was born with Tourette's, but I can still have a very negative attitude toward that child. And that gap is really, really hard to fill. And that's where kids need help. So the element of something called social desirability really plays a huge role, particularly in the middle school years when kids are much more aware of their social status and how they're perceived by others. So this is just a little cartoon outlining the concept of social desirability. And it really means that it's a tendency for children and adults for that matter to portray themselves in a positive manner that's socially acceptable. So particularly for the older children moving into adolescence, they may fully acknowledge and understand logically that kids with neurodevelopmental differences were born with them. They don't do them on purpose, they can't control them, but they're also acutely aware that their own social status is potentially at stake. So if they decide to sit with that child at the lunch table, well, what are their other friends going to say? Or if they, sit with a child who has autism and, appears to be having some difficulty, what are their friends going to say? And back to those sex effects, we did see that girls in our study had a much more favorable attitude if they were shown the video depicting a girl with Tourette syndrome. And the same was true for boys. And in past literature, most of these interventions have boys in them. I mean, prevalence of boys having Tourette syndrome is higher, but there haven't been that many studies looking at sex effects of who is presenting the video, the information rather. And kids who had empathy incorporated into their video, they were more likely to have improved attitudes toward the child with Tourette syndrome. And kids who were older had a higher level of empathy for the child in the video compared to younger children. Going further, kids who had the greater increases in empathy were more likely to interact socially with the child who had Tourette syndrome. And that's really important because it has been a huge struggle for lots of in-services and other interventions and anti-bullying campaigns to kind of really make that leap. And that's something that we were able to see in this study. So again, children who had the greatest positive change or increase in empathy, they were much more likely to interact socially with the child with Tourette syndrome. So here's a graphic of how each video changed the child's empathy, and which video kind of mattered the most as far as that. And while it matters to a certain point how much knowledge a child is provided about a particular disorder, the key here is to find ways to repeatedly increase a child's emotional awareness and empathy toward others. And this can happen at school, at home, and in lots of teachable moments throughout the child's day. This chart is looking at empathy scores. It looked by video, what video you got, whether you were in third and sixth grade, and by your gender, by boys and girls. So what we see here is kind of the older kids had greater amounts of empathy compared to the younger children overall. But there were really, and boys had a little bit less empathy than girls as well. So I just wanted to share a graphic that's pretty powerful of where empathy kind of resides in our brains. And if you look on the left side, that orangey yellow portions, that details where we feel and process pain in the brain. And on the right, the same portions of that system, or it's called the anterior cingulate cortex, they're activated. So I thought this was interesting. Empathy is pain, but sort of. So compared to previous research, this study used the novel element of first-person perspective of Tourette syndrome, knowledge, change, and empathy. Children had an increase in knowledge overall, with the empathy video group having the least changes in knowledge. Older children had more empathy than younger kids, and there was a clear relationship between higher knowledge of Tourette syndrome and more positive beliefs. But those positive beliefs didn't always translate into action toward a peer with Tourette syndrome. So there's a clear relationship between higher knowledge of Tourette and more positive beliefs about a peer with Tourette syndrome, but the leap isn't made necessarily between a better belief about a child with Tourette syndrome and their likelihood to interact socially with them. And that goes back to those social desirability effects we were talking about earlier. So regarding some outcome measures of beliefs, attitudes, and behavioral intentions toward a child with Tourette syndrome, empathy was really this novel element and accounted for a considerable portion of participants' positive beliefs, attitudes, and their willingness to engage socially. So, do you want to sit and have lunch with me? Do you want to come to my birthday party? Do you want to come for a sleepover? Let's hang out after school. I mean, these are all things that as parents we want for our kids, and things that these children as a collective group struggle with every day. We talked about earlier that long-term struggle in social interactions really has repercussions throughout the lifespan. So how can we increase empathy? Well, first off, in my opinion, and some people may disagree, I feel like we need to stop using the term special needs. The term special has really become a euphemism for separate. And people may disagree with me, but I see kids with neurodevelopmental differences as a really diverse part of our population. 15 to 20% of individuals worldwide have some kind of difference. And like other forms of diversity, the presence of those that are differently abled really enriches our humanity in so many ways. And it's nothing to be ashamed of or scared of. Our children's needs really aren't special. They all need to access the same things in life. It's just how they access them that may be different. But the needs themselves are not special. And we all have a right to access those needs. So, and if words matter, there have been recent studies out of the University of Wisconsin-Madison and University of Kansas on the particular term special needs. And it was found that it was an ineffective euphemism for that. So when kids don't meet that narrow definition of what, quote, normal is, they continue to be marginalized. So a couple things that we can do to increase empathy, speaking to parents and caregivers first. So in addition to, we start with good examples at home. So in addition to asking your child how they did on an exam, you might want to consider something like, were you kind to the other children in your class today? Paying attention to how you talk about others, even when you don't think your children are listening, especially people that are different from you. Teaching empathy to kids requires that you model empathy for others. So model really that you prioritize caring. Be your child's emotion coach. And what that means is just learning to identify and manage your own emotions. That's really the first step in understanding others. I have come home many times frustrated or tired or, just kind of depleted, and openly saying, I had a really bad day today, or I feel really frustrated because I'm sad because whatever happened during the day. It's normal to feel emotions, and it's normal to let your kids see you feeling emotions, and see how you're coping with those in a positive and adaptive way. Encourage compassionate perspective taking. I'm sorry, and encourage their compassionate perspective taking. So children and youth really pay attention to what you say. So, if your child had something on Snapchat or Instagram, you could ask something like, how do you think that child would feel if you saw a text like that? Model this awareness in your own language as well. So you may tell your child, your grandmother might be feeling sad today because grandpa's gone, or because he's sick. I'm going to call her now to see how she's doing, and if there's anything I can do to help. Kind of model that behavior. Expand your children's what I call circle of concern. Many kids are more likely to practice empathizing with close friends or family first. So you could use newspapers, television, TV shows, community events to really broaden your child's circle of caring and find compassion for other people's experiences as well. And encourage your child to listen carefully to others, even if their perspective is really different. And just be patient. Your child or your teenager doesn't always respond with compassion or isn't readily willing to reflect with you on their feelings. And empathy is not something that you like pass or fail. And finding an empathic response can be especially challenging when young people are hurt or angry themselves. Kids and adolescents, they practice and develop empathy over years. So really just being patient. And lastly, just stop, rest, and reflect. I think last month, Dr. Sherbakoff provided a webinar here on mindfulness. So really prioritizing time for reflection. What happened during your day? How did you feel during your day? What were some of the emotions you felt? Mindfulness and really rest. So teachers are our first line of defense during the day. And I really believe that wholeheartedly. Teachers are with our kids 8 hours a day. Sometimes more if there's extracurricular activities. So, what teachers can do is, again, model empathy. When you're frustrated with your students, as I'm sure happens multiple times a day, let them see you pause, take a deep breath, take a minute, close your eyes, try to see the situation from their perspective before responding. But let them see how, kind of you experience emotions and how you adapt to them positively. Be aware of students' nonverbal cues and really follow up on them. So for example, if you see a student, slumping in his or her chair, appearing angry, beginning to get dysregulated, saying something like, I noticed you're more quiet today than usual, or I noticed something might be bothering you. Kind of saying this, when appropriate and within reason, instead of sit up in your chair and pay attention, which can be perceived as reprimanding to a child, that can often go a long way in a child's day. Ask for students' input and feedback when it's appropriate and when it's feasible. So for example, when establishing classroom rules or generating ideas for group projects, find opportunities to incorporate their feedback when possible. Give examples on how to act on empathy, such as helping, showing kindness, or even simply listening. And practice empathy, creating opportunities to practice taking someone else's perspective. Imagine what other people are thinking. You could do role plays, read and discussing books that are designed to teach and build empathy toward children in specific situations, and using kind of a what would you do style vignette. It's often very helpful. There's a series of books that are published for specific areas of differences that you can use in the classroom and help increase awareness. And I'll show you a couple of those in a couple of slides. Set pretty clear ethical expectations. Expect your students to care about one another and kind of go through these. Have like an ethical set of rules in your classroom. Establish guidelines for unacceptable language and behaviors. Enlist students in establishing these rules and really check in with students. So there's a couple systems some teachers opt to use. Kids could pick a number at the beginning of the day. Like 1 means students doing really well, 2, you're doing okay, 3, yeah, you're not feeling so great, and 4, you're not doing well. So that can really help teachers clue into the emotional climate of their students. when possible, teachers are, fully engaged throughout their day. Teachers could possibly check in directly with the students who indicated they're having tough days, or maybe have them visit the guidance office for a check-in to help them have a more positive day. I know this is done, quite a bit among the school districts, educating the school community. If you have a child in your school community with a specific disorder, such as Tourette's or autism, training school staff is really critical. I came across this recent study, I guess it's about 4 years, 70 school-based speech language pathologists. And they found that about 85% viewed bullying of children with autism as serious or somewhat of a problem. That's a lot. They all agreed they should intervene in acts of bullying, but not all felt comfortable doing so. Kind of felt that it wasn't necessarily their place, or might be stepping on someone else's toes. 78% were in a district with an anti-bullying campaign, but only 20% were in a district where that campaign focused on children who are uniquely at risk. Increasing supervision in high-risk areas. So this is kind of having extra eyes in areas like the bathrooms or the school bus line at dismissal, the lunchroom. These are core areas where bullying happens because there's just not enough supervision, loud, and kids are able to take advantage of that. Teachers really need to have ongoing discussions about what they're seeing, because what you find again and again is teachers and staff may be reluctant to take action when they're not sure what happened. They may have just kind of walked in on a situation or just gotten one side of the story. And when teachers can really consult with each other, they can become more clear on a potential toxic situation. And on a positive note, studies are really showing that bullying may be decreasing over time. So, these policy and cultural shifts, really, they can make a difference. Know the bullying policy for your school district. Become aware as parents. Have it. You almost always on the school district's website. Understand, but just understand that these programs, they're not often evaluated to see if they're effective. Contact the teacher if there's a problem, and then kind of go up the line to the principal, superintendent, and the school board if necessary. Know the state law for your state or policy for your state. And really, if all else fails, you can go to the U.S. Office for Civil Rights and make a claim there, because your child's civil rights, if they are repeatedly getting bullied, are being violated, particularly if the bullying persists without adequate intervention from the school. A couple of resources I wanted to give. These are a couple of storybooks that can be used in the classroom. Some of them are a little older, like I Can't Stop and the Taking Tourette Syndrome to School. That's a whole series with a number of other disorders, Taking Autism Spectrum Disorder to School, etc. And some of them are newer. Tully and Me is newer. And then there's this series by Susan Yarney for Can I Tell You About ADHD? It's really a guidebook for kind of friends, family, to kind of give an overview of that, so that can help build some understanding. These are a couple of resources and links that you can use. The first is for the Stop Bullying programs that are from the U.S. Department of Health and Human Services. So you can kind of get a sense of what those programs are. The U.S. Department of Education, and there, many people who have kids either on the autism spectrum or with Tourette's or other disabilities, learning differences, have an IEP in place for their child. But if you want kind of a nice overview and a guide to that IEP process and what it provides, how it works, there's a link there to that IEP process. If you find that your child hasn't had a full evaluation and you think that would be helpful, you can certainly talk to the child study team at your child's school district, express your concerns that the child's having in the classroom, out of the classroom, and see if there's a way they could offer you a learning and or a cognitive evaluation. You could speak to your pediatrician or neurologist. You could speak to a licensed provider to inquire about a neuropsychological evaluation. And we here at Neuroabilities provide diagnostic and treatment care for individuals with a host of neurodevelopmental and neurological disorders. And I put our website there and our phone number. And now I would like to open up to questions.
Okay, and I think we're ready. Great presentation, by the way. Thank you. All right, so I have a question about what the neuropsychological profile looks like in a child with Tourette, and how important is that to do?
Well, that's right up my alley. So that's a great question. Tourette's is one of those disorders it has been studied pretty extensively. In the brain, we see dysfunction primarily in the basal ganglia, kind of a subcortical structure responsible for movement. And there's been a variety of impairments related to kind of frontal dysfunction that have been observed in individuals with Tourette syndrome. And those impairments, you see them in various domains found in a neuropsychological evaluation. So, for example, we see them in attention, memory, executive function. So that's kind of that planning, the frontal lobe, which I call the brain's manager, helps you plan, initiate, organize, and complete tasks, time management. It can impact language, functionality, motor and visual motor functions, among others. So specifically, it's been proposed that tics might be caused by this unexpected activation of specific cells in the brain in the striatum, so which would lead to the production of these unwanted movements. And there's been pretty robust evidence for individuals to have a lot of impulsivity on certain tasks. So, we do see a lot of executive function deficits in planning. Kids often have difficulties doing fluency related tasks. So, reading both, accurately and efficiently, or doing, math problems quickly. We can see some deficits in some cognitive flexibility. So kind of switching gears quickly is tough for these kids, or can be tough. And as far as overall intelligence, so there might be significant variance in intelligence across Tourette syndrome folks, but really there's only slight impairments in general intelligence that are usually reported. There's really no intelligent factor or impact.
Mm-hmm. Mm-hmm. So how long would, just addressing that, how long would that kind of evaluation take? I mean, is that spread over a couple of days, or is it all in one session? Just a little bit of a explanation there.
Yeah, that's a good question. So if you go to your child's study team at your school, the school psychologist will typically conduct that evaluation, or someone kind of working with the school psychologist. So those are done during the child's school day. It's not after school or before school. And it's done kind of a little bit here and there. If you put in writing that you're requesting an evaluation of your child, the district typically has about 60 days, so 60 days, to complete that evaluation and provide you with a report. The school evaluations typically include, they're leaner, and they're designed to see where your child may be having difficulty academically, since they're responsible for your child's academics.
Mm-hmm.
So really do like an IQ test and some academic measures, and then some screening measures of emotional function that the parent will complete and the child will complete. You have a neuropsychological evaluation that goes, much more in depth beyond just kind of IQ and academic. That's really the child's language, memory, attention, etc. So it can take just a couple hours over several days if you go the school route, or if you seek a private practice or another clinician. Typically, they're done over 2 3-hour sessions, so 2 half-day sessions. Some folks will do it in one day, about 6 hours, but often in children, the fatigue level,
it's kind of hard.
Yeah, and it's not really valid if you have a tired child.
Okay, all right, thank you. Question about the empathy. Were participants, regarding where the child actor was used here, so were participants more likely to actually interact with the child actor, or hypothetically say that they would?
That's a great question. It was hypothetical. We did not bring the individual directly into the classroom to see. That would be a much bigger study. over kind of a longitudinal period of time. So yes, so this was hypothetical. This wasn't. This was kind of how children said they would what they said they would do, and to minimize the chance that the child would respond positively because somebody's going to judge me for what I'm saying. These kids were allowed to conduct the measures, individually. They weren't next to a peer or near a peer who could see their responses.
Mm-hmm.
Everything went right back in an envelope that was sealed that nobody could see. Trying to minimize some of those social desirability effects. But yeah, I mean, the next step would be to kind of try and integrate a child, into the classroom to do some kind of study in that format.
Okay, thank you. So in terms of empathy, again, I have a number of empathy questions here. Would you say that if it's modeled at home, it would have a greater or the greatest impact, let me put it that way, so that the environment at home that's like present for the child all the time, that empathy, and that would be the place where it would be the most effective?
So meaning kind of empathy should begin at home, is that kind of?
Yeah, I would think that's where we're going with this question. Yeah.
Yeah, I mean, empathy is one of those things that is built over time and with repetition and practice and experience. So kind of having these experiences repeatedly, so that you kind of can build these skills. So yeah, I think it's always helpful. I mean, a parent can't be with their child 24 hours a day, 7 days a week.
Mm-hmm.
But trying to demonstrate empathy as much as possible at home, and within reason, and and as it's appropriate. You don't want it to be contrived. And like I said, you don't want it to be kind of this empathy lesson, but it can be taught at home. It can be taught in religious settings. It can be taught in a number of places. Kind of, like I said, empathy is kind of caught, not taught. So it can be through, if your child's on a sports team and somebody gets hurt, kind of, wow,
Uh-huh.
how do you think they really feel? Beyond just the fact that maybe their leg is hurt. Do you think they're upset that, maybe they can't play right now, or they may have to take a break from soccer for a period of
Okay.
time, whatever that is.
All right, another empathy problem. Now, this is apparently causing a family situation. So the problems with modeling and so forth, in this particular instance, there's a high school niece who does after-school care. And they've tried to, and so apparently this high school after-school care person is not handling issues well with the child that they're watching, and says things that don't reflect the family's standards, I guess. And but she doesn't seem to understand. They've tried talking to this high school student, and she doesn't seem to get it, and it's causing problems in the family. So short of finding somebody else to do after school care, could you make some suggestions about maybe how to handle that?
So let me just to clarify. So it's a high
Mm-hmm.
school student who's providing after school care for a
After
young
school
child,
care for a younger child, yeah.
and they're saying
And it's
things.
in the family, so it's a niece, and so she's watching, and I would assume from this that she's probably doing some babysitting. And there's just this uh, ineffective way that this girl is behaving around the child that the parents are concerned about. So
Okay.
short of just moving on and trying to find somebody else, would you make any suggestions about how to handle that in the family?
Well, I would assume this niece is old enough to be able to be, babysitting and providing care for a younger child.
We would hope, yes.
I would think that, kind of a calm, delicate, not in the moment conversation. So not right after they may have caught or heard this individual saying something like, if the younger child's crying, saying, "Oh, just get over it." Maybe not in that moment, but maybe in a moment kind of separate from that situation, to kind of let that high schooler's defensiveness come down a little bit.
Mm-hmm.
Explaining that, this is, this is a young child, and this is your cousin, and she's young and she may not quite understand, kind of delicately saying, how can we together, if you allow the individual to kind of feel like they're having a collaborative discussion and collaborating on how to, change or do things differently, maybe not using the language how to do things better, but how to do things differently. Sometimes that helps to get high schoolers buy-in when they're at a developmental stage when they think they're right about everything.
Yes, I like the collaborative idea, though. You're absolutely right. Not in the moment and have it turn into a big ruckus in the family.
Like an I'm right, you're wrong.
Yeah.
Exactly.
Yes. Okay. Thank you. Do kids with Tourette or autism often get diagnosed with learning disorders, or is it the other way around?
Well, that does certainly happen. So there's a lot of overlap with kids and learning disorders, with kids with neurodevelopmental disorders and learning disorders, and there's certain risk factors for having a learning disorder among the Tourette syndrome population. So gender is a big factor. Boys have been shown to have more learning difficulties than girls. And age of symptom onset is also a factor. You started showing your symptoms a little early. If you think about it, if you're if you're 5 years old, 6 years old, when some of the kind of critical early reading, letter development, letter recognition skills are being taught, and you're having these tics and these symptoms, it's really overwhelming. And it's scary at first, the child who's having that experience. So that, your attention is away from the lesson at hand. Tic severity is another factor. So it's tough to parse out what is a function of Tourette's and what's a function of an executive function deficit and the like. But what we do know is kids who have Tourette syndrome are at a higher risk for developing a learning disorder. So I think I recently saw a statistic where kids with Tourette syndrome and a learning disorder, 80% of them also had a diagnosis of ADHD. So there's certainly quite a bit of overlap there.
Okay, thank you. We have a question about school refusal. There was apparently a bullying situation that the school is ignoring, apparently. So how, the question is, how do you handle a school refusal because of bullying that the school is ignoring?
That's my heart goes out to whomever is experiencing that. That's a really difficult thing, and I'm sorry that the school isn't doing more than they should be. So, it's a really vicious cycle. The bullying kind of happens over and over and over. The child, it's not surprising, and school refusal is a huge issue among the kids, the victims who are bullying, and it really stems from this overall sense of anxiety, this dread that occurs. My recommendation would be to call kind of an emergency, meeting with school, the guidance counselor and the school psychologist to discuss this. If the child is having school refusal, that the school may temporarily send in homebound instruction to encompass a couple of hours of the child's day, so they're still able to get instruction, and really kind of building in some behavioral supports to try and get the child back into the school system. School refusal is a difficult thing, and if it goes on, it becomes very it's a way to avoid an unpleasant experience at school.
And the longer you stay out, the more difficult it is to get back in there too. So that's the other side of that. Yeah.
It's very reinforcing. So kind of, parents in a difficult situation because, you don't want your child to have to experience that, and you feel like you're throwing them, to the lions every day. But, really there's kind of like building some supports over time back in, so that the child, maybe only goes for 2 hours, 3 days a week, to slowly begin to go back and reintegrate into the school. But, certainly there has to be plenty of supports in place at the school as well.
Okay. Would you talk a little bit about OCD? And the question is about OCD that is specific to TS. So the question goes on a little bit further, that OCD in TS is not like OCD that most people think about. In the example she's giving here, that the daughter is the messiest person with OCD that she ever met. So is there a distinction with the OCD that accompanies TS or is comorbid with TS that's a little different? Is there any evidence of that?
Well, yeah, and you expect people, or in colloquial terms, we think of OCD as a really like a neat freak or a neatnik, but a lot of times it's just really specific to only certain areas. So they could have a messy room, but have certain obsessions and compulsions that they have to do. So OCD and Tourette syndrome, they exist as separate entities in the DSM. OCD is classified as an anxiety.
Sorry.
But there is quite a bit of symptom overlap. And there's a lot of evidence that OCD and Tourette's overlap in ways that suggest that there's a pretty close relationship. Because the frequency that those two disorders occur is a pretty big clue. I think 60% maybe also of Tourette's syndrome, kids diagnosed with Tourette's also have OCD symptoms. So I don't know if the question is, is there like, is it OCD or is it Tourette's? It's really tough to parse out. I mean, OCD is kind of a more specific type of compulsion. So, it may be that, you have like this fear of germs or excessive hand washing, tapping something repeatedly. That's really not a tic. That's not, that doesn't fall under the same umbrella as motor and vocal tics. I don't know if I answered that question. Hello?
Hi, sorry, Marty is coughing right now. So,
Oh,
so we had somebody come in and comment that teaching tolerance, so much of that begins with family values and attitudes that are modeled. So, and towards people with differences. And so they just wanted to get that in there. And Dr. Newman says, I think OCD that goes with TS is often about counting and symmetry. And yeah, we do find that, and we find that kids with OCD and Tourette syndrome call it tics of the mind.
yes.
So I have a woman who's got who teaches in a school that is for behavioral disorders. She says that she has a student with severe verbal tics, noises, throat clearing, which is difficult for other students to handle. Although she's talked to her students that this individual can't help it, some students are better at understanding than others. Are there any suggestions to help students tolerate the other one's noises?
That's a tough one, because like you said, the child isn't doing these things on purpose, and yet all of the kids have a right to learn and to access the curriculum in a way that's suitable for them. So I think you can. That is a tough one. Perhaps try to position, you don't want to move this child with the verbal tics in some other way, but perhaps allowing him or her to kind of there's often this premonitory urge before a student or a child is going to begin engaging in maybe a bout of tics. So kind of allowing the child some freedom to excuse him or herself in the classroom, to feel more comfortable, to kind of allow that release, and then return to the classroom when they're feeling, they're feeling better. And then the teacher may have to get a little bit creative, just kind of being persistent and patient. Just keep reminding the students that this isn't on purpose. Maybe building breaks into the lesson so that the anxiety level of the classroom can come down a little bit as needed, and just kind of like yeah. So it's a difficult thing, but if it is presenting, I don't know how many students are in the class, but there may be some other creative options that the learning support team can come up with to kind of help support that student a little bit, better, and allow for less distraction for the rest of the class.
Okay, so we have one last question to ask at the moment. So, how do you help a child maintain friends? My child seems to be able to initiate friendships, but they tend not to last. And she's around 9, and she does have Tourette syndrome.
Okay. Well, it's great, and it's really positive that she's able to kind of initiate friendships. And a couple of things that parents can do to support friends. She's 9, you said. Sometimes adults take this opinion like, well, children need to work it out for themselves, and sometimes they do. But rarely do kids at that age group learn that fine art of friendship without some support or role modeling about healthy relationships. So, if this is a shy child, they may need to learn, to not respond to certain types of peer conflict with like fear or worry. Find your child's strengths, welcome your child's friends to your home kind of repeatedly. It may feel like I'm always the parent having my kids' friends over and nobody ever invites him or her over. They don't reciprocate, and that's okay. That's a valid concern and frustration, but continue to welcome that child's friends to your home. If kind of offer some kind of like fun activity for them to do, make it like a place where kids are going to have fun, feel comfortable, and enjoy being with that child. If there's an opportunity for that child to kind of join some clubs or some sports or other events, that they can become more involved consistently. So maybe not just seeing this child and their friend in a classroom, but also seeing them on the field, or also seeing them in an art club or something like that. And for the parent, I often recommend that parents try and get involved as they can. I know parents are very busy with jobs and many competing priorities, but trying to get involved in your child's school, to kind of be there and see what's going on. You're able to kind of have some eyes and ears on what's going on in your child's day, who they're hanging out with, what some of those interactions look like. And at 9, parents are still kind of scaffolding their child's social structure and social plans. So trying to kind of facilitate some of those play dates or activities or things with other parents is still really helpful at this age. Kids don't usually have phones at 9, although I may be kind of out of the loop in that one. But just kind of keep facilitating some of the interactions with students, and giving them like casting a wide net, like giving them a wide variety. If they say, well, I only want to hang out with this person, try inviting someone different. I hope that was helpful.
It was. One note, we had a parent say, type in about the loud noises. When he was having verbal tics, the teacher played some soft background music in her classroom, and she also would give out sugar-free candy so that her son could suck on something, which helped suppress his tics. So I hope that makes that helpful for that other question. Dr. Theobald, I really appreciate your time, and thank you for doing this webinar. It was quite helpful and quite full of a lot of information. Thank you all for joining us. Our next presentation on developmental consideration for OCD in kids, teens, and adults will be given by Dr. Jacqueline Gola and is scheduled for March 18th, 2020. There is an exit survey, which we need everyone attending to fill out. The webinar blog is open now and available for the next 7 days on our website for any additional questions that were not covered in tonight's presentation. The website is www.njcts.org. Also, an archive recording of tonight's webinar will be posted to our website. This ends tonight's webinar. Thank you, Dr. Theobald, for your presentation, and thank you everyone for attending. Good night.